Hello and welcome to the webinar. My name is Sabrina Edgington. I'm the Program and Policy Specialist with the National Healthcare for the Homeless Council, and I'll be hosting today's webinar, Care Transitions for Patients Experiencing Homelessness. This webinar is supported by the Health and Services Administration Office of Special Population Health. This is a one-hour presentation with the last 10 minutes reserved for Q&A. Please type your questions or any technical issues into the chat box. We will respond to your questions at the end of the presentation. The PowerPoint presentation and the recording of this webinar will be posted on our website at www.nhchc.org within 72 hours. I'm very pleased to introduce our two speakers today. Our first speaker, Meg DeVoe, serves as a general internist at Central City Concerns Old Town Clinic, which is a federally qualified health center in downtown Portland that has integrated addiction, housing, and mental health services. Meg's current academic focus is that of a clinical educator at Oregon Health and Science University, where she strives to teach future physicians about social determinants of health. Our second speaker, Honora Englander, is an assistant professor of medicine at Oregon Health and Science University in the Division of Hospital Medicine and at Old Town Clinic, where she focuses on care of patients transitioning out of the hospital and emergency department. She's the medical director and co-principal investigator of the Care Transitions Innovation, or SITrain. Dr. Englander recently co-authored a review of readmission risk prediction models published in JAMA, and she senior authored a qualitative study of multidisciplinary provider perspectives on transitional care gaps that is in press in the journal Internal Medicine. She was recently honored by the American College of Physicians Hospitalists as one of the nation's top docs for 2012. Before Meg and Honora begin their presentation, I'd be remiss if I didn't mention some of the care transition initiatives that are being implemented as part of health reform. So this slide that you see includes a list of some of the major health reform initiatives that emphasize care transitions. The Community-Based Care Transition Program was launched last year as part of the Partnership for Patients initiative. It's a 5-year program that tests models for improving care transitions from hospitals to other settings and reducing readmissions for high-risk Medicare beneficiaries. The Hospital Readmissions Reduction Program is a program that many of you may be familiar with. This program reduces Medicare payment rates for all acute care hospitals that experience higher than average readmission rates for 3 conditions, which are heart attack, heart failure, and pneumonia. And improvements in care transitions are expected to reduce these readmissions. The Physician Quality Reporting Initiative establishes the Physician Compare website, which is intended to provide Medicare beneficiaries with information about provider performance, including in the future assessments of continuity and coordination of care and care transitions. And in 2019, the Secretary of Health and Human Services is able to establish a demonstration program to steer Medicare beneficiaries to these higher performing clinicians. The Federal Coordinated Healthcare Office was established to ensure that people who are dually eligible for Medicare and Medicaid get full access to the items and services to which they are entitled. The 6th goal of this new office, as mandated by the Affordable Care Act, is to improve care continuity and ensure safe and effective care transitions for dual eligibles. The state option to provide health homes for enrollees with chronic conditions allows states to amend their state Medicaid plans to provide health homes to individuals with certain chronic disease and receive a 90% federal match for the first 8 quarters that the program is in place. Among the health home services that must be available to participating Medicaid beneficiaries is comprehensive transitional care. And the Medicare Shared Savings Program facilitates the development of accountable care organizations to improve quality of care for Medicare fee-for-service beneficiaries and reduce unnecessary costs. The Centers for Medicare and Medicaid Services believes that assessing care coordination, and in particular care transitions, is an important aspect of evaluating the overall quality of care furnished by these ACOs. Please check our website for an upcoming policy and practice brief that describes these initiatives and others in more detail. The brief also describes several evidence-based care transition models and includes recommendations for practice and policy. While a number of care transition models have been established, most target Medicare beneficiaries. Few have been established to meet the needs of low-income, underinsured, and uninsured patients, including patients experiencing homelessness. The SITrain model is innovative in that it does take into account these populations. And with that, I'd like to welcome our first presenter, Dr. Meg DeVoe.
Thank you, Sabrina. So the title of our talk is Hospital to Home Transitions, Lessons from the Care Transitions Innovation. And again, I think we use the term hospital to home, and what we probably really mean is hospital to community transitions, because we recognize that many of our patients are facing homelessness at the time of discharge from the hospital. So we wanted to start with just sharing a quote with you from Atul Gawande, a physician and journalist, that maybe will get us all thinking in the right frame of mind. He says, American healthcare is an appallingly patched together ship with rotting timbers, water leaking in, mercenaries on board, and 15% of the passengers thrown over the rails just to keep it afloat. But hundreds of millions of people depend on it. There is no dry docking healthcare for a few months or even for an afternoon while we rebuild it. If we get things wrong, people die. This doesn't mean that ambitious reform is beyond us, but we have to start with what we have. And so we believe that by reviewing what others have done to improve care transitions, as well as describing our own experience with local innovations, that we can offer some hope that the system can be patched together. And I think this is a simple but powerful sentence. A bridge without a destination is just a plank. And as you'll see, we also think a big problem for many patients facing homelessness and other disparities at the time of hospital discharge is ensuring access to ongoing health care. So we'll sort of dive in by defining transitional care. Eric Coleman defines it as a set of actions designed to ensure the coordination and continuity of health care as patients transfer between different locations or different levels of care. And again, our focus today is on the hospital to community transition. And throughout the talk, we'll share some quotes and findings from our patient and provider needs assessment. And here in Portland at OHSU, Honora sort of developed this Care Transitions Innovation program called SITrain, and we're going to share the experience of developing that program with you. So our objectives today, we hope to demonstrate that in such a complex and large healthcare system, an understanding of national, regional, and local needs and opportunities for improvement are all important. And so we hope to sort of understand transitional care importance and current gaps, provide a brief overview of interventions, and highlight the limitations for many patients facing homelessness. We're going to describe local needs assessment and program development here, and then suggest strategies for improvement. This map represents readmissions, 30-day readmissions after hospital discharge by region. And there's a growing spotlight on transitional care because hospital readmissions are common and costly. These readmissions represent $17.4 billion of Medicare costs annually. And recently, Medicare has started to penalize hospitals for 30-day readmission. So it's easier for us to predict if someone is going to die than it is for us to know if they're going to get readmitted to a hospital. We just don't have a good way to predict readmission, and this is an important issue as we try to understand transitions of care. So there's a variety of factors that can contribute to readmission risk. There are patient factors, such as comorbidities, social support, housing, and literacy. There are system factors, such as the quality of inpatient care, access to post-discharge care, and even the supply of beds available in a given hospital system. Many models don't include social factors that may play a large role in readmission risk. And we think that transitions of care improvements need to be able to respond to these complexities and not be unidimensional. They need to respond to different patient needs and bridge important care gaps at the time of discharge. So why are transitions hard for patients? It's a really abrupt shift from a provider-centered care to patient self-management. If you sort of just imagine moving from the hospital to home or community environment. Patients are often ill-prepared. Education of disease processes and self-management is often hurried. Patients are ill. Social supports may not be present. The regimens are complex, and there's little time to sort of do effective teaching with kind of a teach-back system to ensure that the patient has adequate understanding of follow-up needs and new skills that they'll have to have. And there's really sort of a silo effect of how we deliver care, with kind of hospital care being on one end and then care in the community being very separate and in a different realm. This patient poignantly describes the patient experience of gaps in transitions. He says, so all of a sudden I went from this controlled setting here with people watching out for me and taking care of me, so I'm out there in the real world bounding around and no real place to live as of yet. You know, it's just like, it's like a big roll of the dice. And not only are patients ill-prepared for care transitions, but so is the healthcare system. So this quote comes from a healthcare administrator who says, we don't have a community contract where everybody acknowledges their role. My role as the sender is to do these things. My role as the recipient is to do these things. The who, will, and how of the handoff. We never get close to that sort of formality, which is really what any smart handoff or transition would require. So with the patient confused and the healthcare system confused at the time of transitions, it's not surprising that transitions are a risky time. There's a robust body of literature that highlights gaps in transitional care and risks associated with poor quality transitions. And these risks include adverse drug events, delays in diagnosis and treatment, poor patient satisfaction, potentially preventable readmissions, and bad patient outcomes. And again, the literature so far is really focused on the preventable readmissions. And so I'm going to hand it off to Honora to familiarize us with the intervention literature that exists.
Great. Thanks, Meg. So our understanding of the folks who are in the audience is that there's a mix of clinicians and community organizations, and so we felt like it would be useful to ground this conversation in some of the improvements that are described in the literature, and this also maps to our process in terms of developing SITrain, or the Care Transitions Innovation, which is our own local program that we have implemented and studied. I'm going to highlight some of the most widely known interventions to date, and one of the things to note is that many of these interventions don't explicitly address some of the social determinants, and and these determinants may really drive some of the complexities of transitional care for more vulnerable patients. But at the same time, they really can have some very valuable lessons. And so Project Boost is part of the Society of Hospital Medicine's work. It was developed for older adults primarily. And on their website, they have a number of sets of tools really to optimize discharge planning. The vantage point that they use is that of the hospital, but they have specific tools to focus on communication from hospital to primary care clinics. I think some of this could be also useful in terms of thinking about transitions from hospital to recuperative care programs or respite care programs, and they really incorporate a number of best practice insights. They're smart about implementation. For example, there's a letter to hospital administrators to try to appeal to some of the sort of stakeholders. And while the Boost work is very useful, it's not yet rigorously tested or studied. So I will go through sort of several of the major studied interventions. And to begin, Eric Coleman's work really is sort of some of the foundational work in this area. And his work out of Colorado primarily focused on older patients and with one of 11 high-risk conditions. Their study was done in an HMO single hospital setting. So that, again, I think is a really important consideration as each of us think about our own local context. And the model that they used was a nurse-led intervention primarily focusing on health coaching and education. So the idea is that older adults would be coached to reach out to follow up with their primary care providers if they had questions about their health. Not that the nurse or coach was doing things for patients, but really helping patients learn how to navigate the complex system. And they used RNs there, and they found an absolute risk reduction of 3.6% in 30-day readmissions. I think this is a really important model, and some of the references that Sabrina mentioned earlier really refer back to Coleman. I think it may be interesting to think about for patients who have needs around housing, have complex mental illness perhaps, if a coaching model would be applicable or not, and so those are really important considerations. Mary Naylor's work also focused on the older adult, in particular with one of 10 high-risk conditions. And in her model, it was at 2 academic hospitals in the Philadelphia area, and she used advanced nurse practitioners who helped with patient-centered discharge planning, also home visits. And I neglected to mention with Coleman's model there is a home visit component, and she found an absolute risk reduction of 16.8% over 6 months. The Project Red work is a little bit different in that this was in Massachusetts and was focused primarily on socioeconomically vulnerable patients. Was performed at Boston Medical Center, which is a large academic medical center in Boston. And I think it's important to know that this work was developed in Massachusetts where there was universal health care. So perhaps quite different, certainly from our experience here in Oregon where we don't have universal access to health care. And that model used a nurse discharge advocate who conducted scripted, intensive patient-centered education during hospitalization that really focused on patients' understanding of their diagnoses, around their understanding of how to schedule outpatient follow-up, and having a point person at discharge. And then there was also a pharmacy piece to their intervention, whereby a pharmacist contacted patients several days after discharge, again to review medication. And they found an absolute risk reduction of 5.3% in their 30-day readmissions. So these are sort of, I think, helpful references, and how these tools may be applicable to one setting is important to consider. One of the things that's important to note is while there have been several what are deemed as successful interventions based on their ability to reduce 30-day readmissions, a number of programs have failed. And in fact, this is a paper that describes a Medicare demonstration project that evaluated 15 Medicare care coordination projects. And what they found was that 13 of the 15 were unable to reduce Medicare expenditures. And there were 2 programs that showed the most promise. And I think that the lessons from what were felt to be the more successful interventions is quite important. So in my opinion, this is an important slide because I think it highlights not only what some of the successful features are, but practices that are important to consider for all of us aiming to really target systems integration. And so these programs found that they had higher rates of in-person contact, that the interventions targeted high-risk patients, and that's a separate and difficult discussion as to what do we mean by high-risk patients, but I think targeting interventions and targeting the appropriate intervention and kind of appropriate dose of an intervention to the appropriate patients is really important as we think about allocating these resources. These interventions provided better patient education, and they had excellent cross-site communication. So moving forward, there are some really important lessons from the national experience, highlighting that communication, patient education, and also access, certainly, in the patient population that we're speaking of are really important. And that interventions that had a bridge seem to have the most promise. In our own experience in terms of developing SITrain, or the Care Transitions Innovation, which we'll talk more about, I really think that there's no sort of off-the-shelf improvements here, and considering local context and understanding really what are the sort of what, how, and who of interventions really make an important difference. So I want to talk a little bit just to kind of foreshadow about what we mean by SITrain, and then Meg's going to take us through our own program development, and then I'll kind of talk about the specifics further from some of the details about SITrain, but just to sort of show you where we're headed. SITrain is a hospital to community transitions program for uninsured and Medicaid as well as low-income Medicare patients who were felt to be high risk for readmission. And we've developed this here at OHSU, which is an academic hospital in Oregon. One thing that's come along during the years that we've been working on this is the coordinated care organization process. And our intervention is more complex than the interventions I described earlier. We have a transitional care nurse who really serves a bridging role. There's a pharmacy consultation, and we also supply uninsured patients with 30 days of prescription medicines from a low-cost formulary that we've developed. We have strong linkages with primary care in the community, and again, we'll go through this again, but OHSU is paying for primary care for uninsured patients in the community. And then there's really strong efforts at cross-site integration and systems integration. So by cross-site, what I mean is community partners and hospital partners sitting around the same table working on quality improvement. So it is as part of this complex health intervention. And we recently completed a study. We're still in the process of kind of crunching all of our data, but our primary outcomes were 30-day readmissions and emergency department use, as well as mortality, the care transitions measure, which is a measure of quality, and a number of other factors. And in our experience, we've really found that working on this improvement has driven a lot of, it served as a platform for quality improvement and driven a lot of change. So I'm going to start with a patient story to kind of ground our conversation here. And Steve is a patient who I cared for. I'm an internist, and I cared for Steve in the hospital in late 2007, early 2008 was when he was hospitalized. And his story really, it was a patient story that really drove our initial conversations, and so it's an important one to share. He's a 48-year-old man who was uninsured, and he had untreated sleep apnea. And he'd been brought by his father to the emergency department with increasing fatigue and shortness of breath, really over about 6 months. And as the story unfolded, his father explained that he was a long-haul trucker, but that he wasn't able to stay awake at the wheel, which is a complication of his sleep apnea. And he tells us that he lost his job and then subsequently lost his housing because of complications of his medical illness. Steve got admitted to the hospital. For the clinicians in the room, the carbon dioxide level in his blood was 141, which really is incompatible with life. And he was emergently intubated and cared for in the ICU and subsequently cared for on the medicine wards. And I met him for the first time after he'd been transferred from the intensive care unit to the wards and reviewed his prior records and saw that he'd had a hospitalization previously. And during that hospitalization, it was noted that he had a low thyroid, that he had sleep apnea, that he had no primary care, and at his first discharge, he'd been given a list of low-cost clinics. And his story really was one that was very powerful, both in terms of costs to the system of the shortcomings of what we were currently doing and the gaps in his current care, and then also the social and physical consequences of these gaps in his care. So we ended up taking Steve's story, and this was a story that resonated with me as a provider and with a number of other stakeholders. And we ended up having what we called a health systems M&M, or morbidity and mortality conference. And these morbidity and mortality conferences traditionally focus more on clinical decision making. So, was the right antibiotic selected? Was the diagnosis recognized early enough? But not so much an emphasis on systems problems. And so we took an opportunity to talk more broadly about the impact of uninsurance, both on our patient Steve, and we invited him to come and share his story. And then we invited a number of other stakeholders and perspectives from within the healthcare system. So invited inpatient providers, outpatient providers, and safety net providers. We had a representative from one of our recuperative care programs because of his homelessness, and also invited a hospital administrator to come. And we talked about the impact of uninsurance from these various perspectives and showed the costs, both the financial costs as well as the social and medical costs. And early on, this really highlighted that there was widespread interest in terms of improving the system, but also that it was going to be quite a complex task. And this early conference spurred further interest on some of our team's part to pursue support for a needs assessment and really to understand better from a local perspective where we needed to head. So this is a list of our stakeholders, and we've described our work in a publication that gets into it in much greater detail, but I think it's important early on to identify, for those of you that are thinking about improving transitions, it's important to identify who the stakeholders are who might be interested in partnering. And this list of stakeholders evolved over time. It did start with that first Health Systems M&M conference that we had. And as I said before, we invited clinical staff, which included physicians, pharmacists, and care management and social work. I think including the health system leadership early on is really critical. So the process of getting administrative and executive buy-in was one that took a lot of effort and a lot of time, but was really, really important. And I would say that's true both from the hospital as well as the outpatient settings. And then other stakeholders to consider for those of you thinking about your own local improvements would be your Medicaid plans. Certainly patients' perspectives are really critical to this work. I think including health systems researchers for evaluation is very important. We found that a lot of the solutions that we have found most useful have been around information technology and sharing records across settings. So I would include your clinical informatics folks. And then the financial piece is really critical. So from here, I'm going to pass it on to Meg to describe some of the specifics of our own process with our needs assessment, and we'll take it from there.
Thanks, Honora. So after identifying the stakeholders, a patient needs assessment was done to better understand transitional care gaps from a patient perspective. And this involved a survey of adults admitted to the hospital here at OHSU, and 40 semi-structured interviews, as well as a cost of care analysis. And as Honora had previously described, the population we really focused on was uninsured and low-income publicly insured folks. And what we found was that about a third of all patients were marginally housed, 40% had low health literacy, and more than half had comorbid depression. Those patients who were uninsured identified cost of ongoing medications as a major barrier to self-management. So really highlighting that kind of securing those medications and follow-up at discharge was kind of a big barrier for patients to overcome. Our population seemed to have a high utilization rate and difficulty accessing primary care. So more than 50% of participants reported previous hospitalization within the prior 6 months. About a third of uninsured patients didn't have a usual source of care, and 1 in 10 Medicaid patients lacked a usual source of care. And many felt that the self-management demands that were being asked of them at discharge were overwhelming or ill-prepared for them. And then, in addition to the patient perspectives, we also aim to understand provider views on transitional care. And we conducted 13 focus groups and 2 in-depth interviews to better understand provider views. The perspectives were diverse and included in- and outpatient physicians, nurses, pharmacists, social workers, case managers, administrators, Medicaid managed care organizations, pretty much anyone who really would sort of could possibly even touch the patient or have an impact on patient care during that bridge time between hospital to community. And then we analyzed each of the interviews and focus group transcripts using a thematic analysis to identify emergent themes to help us better understand providers' perceived gaps in transitional care. And we selected some of the more poignant themes from the study to share with you today. So the first theme was that transitional care gaps reflect system fragmentation. And this resident physician states, I felt ridiculous that while we could provide intensive care in the hospital, we couldn't provide any of the outpatient care. We couldn't keep him in the hospital because he didn't have any indication at that point, but I felt like I was not treating the patient correctly. And I think this quote highlights the importance of understanding the local landscapes, gaps, and opportunities that exist to try to improve patient care across settings. And the second theme we'd like to share is that psychosocial needs and limited access to outpatient resources present barriers to quality transitional care. A pharmacist said, we just assume everybody can pay for their meds or everybody has insurance. If they don't, there's nobody following up on the other side. Finally, communication across settings is fragmented. A primary care provider pointed out that the package that leaves the hospital now more often than historically includes a PICC line, Foley catheter, oxygen, without a plan for when those are to be stopped and without communication to anyone about who's in charge next. Sometimes we end up with the patients coming back to see us months after they've been discharged. They've been wearing a Foley catheter all that time. It's amazing the way those balls can get dropped. And so from the provider perspective study, we arrived at this figure, which we think represents healthcare professional views on hospital-to-home care transitions. And this figure should really stress you out when you look at it, because I think that was what we really picked up on, is that providers were stressed about really knowing how to provide adequate transitional care to patients that they could really kind of feel in their gut were at high risk for readmission, but really felt like they didn't have a lot to offer in terms of really designing an effective care plan. And so you can see from this figure the silos of the hospital and the outpatient setting and this chaotic and unsystematic transition between those two settings that clearly affects the patient's and provider's experience and can really lead to adverse outcomes in care.
So this is Honora again. I'm going to kind of pick up, thanks Meg, and talk about, we've talked about kind of our own local framing of the process and some of the review of what's been done nationally around these hospital-to-home transitions, and then shared briefly some of our experience from our own local needs assessment of patients and diverse providers. And that was all really critical to both framing our understanding of gaps and opportunities, but we also feel that really understanding the business case was critical to our gaining traction and being able to move forward, and that this business case was a catalyst for both administrative buy-in and kind of getting the support that we needed. And so as part of our needs assessment, we collected charge data, and what we were able to estimate is that there was a greater than $10,000 savings per avoided readmission among uninsured patients. One thing that I didn't explicitly mention in the story of Steve, who was our original patient, was that at that first conference, we showed the cost data from his hospitalization, and he had over $130,000 of hospital bills, and being uninsured, he was unable to pay those bills, and we really used that piece of the conversation to leverage broad-scale interest and show that there's got to be better ways to be spending these dollars and investing them moving forward. So as I said, we combined our own local needs assessment and national transitions experience to appeal to our health system leadership support. And again, this is really critical to our moving forward. And I want to take some time with this slide to show you how we then map specific components from our needs assessment to elements of our program. And so given the fact that patients had difficulty accessing care, many of them had comorbid mental illness and poor social support, we developed the role of the transitional care nurse. And our transitional care nurse meets the patient early in hospitalization, does a needs assessment, and helps the care team anticipate care planning across settings. She also develops what we call a personal health record with patients, which is a patient-centered tool that's a paper tool they can take with them from the hospital to their primary care follow-up appointments and to their home or to wherever they're staying. And it outlines things like what are the red flags and warning signs they need to be mindful of to self-manage their illness. It has a list of their medications, a list of their follow-up appointments. And then our transitional care nurse also does a home visit within 72 hours of discharge for our most high-risk patients, or does phone follow-up for those patients who are deemed to be lower risk and who have phone access. The transitional care nurse role is also kind of the linchpin of the program in that it's a really key piece of the systems integration operationalizing the care coordination. Another thing that we learned from our needs assessment was that, and also from the literature, was that medication complexity and cost were major barriers to patients successfully transitioning from the hospital. And so we developed what we call a value-based formulary, and this is a low-cost formulary. OHSU committed to providing 30 days of prescription medications for patients from this formulary. And the formulary is, and just so folks know what a formulary is it's a list of medicines that can be sort of selected to dispense to patients. And this formulary also mimics medications that are available in some of our partnering clinics and through $4 plans, which at Target or Fred Meyer or whatever, these $4 plans that are available, I believe, nationally. We also developed a pharmacy consult. Low health literacy was a major gap for patients and just the complexity of patients' medication regimens. So our pharmacists, in tandem with the transitional care nurse, work to simplify medication packages to help provide feedback to the inpatient teams to guide prescribing towards this low-cost formulary. And the pharmacist serves as a resource to the nurse who may be seeing a patient at home, and if a question about medications comes up, there's a clear point person. One of the major barriers to successful transitions that we noted also was simply the access issues to primary care follow-up. And I described Steve's story early on. As his provider on the inpatient side, I called all of the 14 low-income clinics in the Portland area and was unable to successfully get him a follow-up appointment. So we felt that we really needed to include, as part of this program, explicit linkages and sort of clear linkages with medical homes in the community, and this also includes payment for primary care, that the hospital will pay primary care clinics to provide that care. We've also coordinated specialty care access, so if a patient needs to be seen in a timely manner by a cardiologist or a gastroenterologist or needs to see a radiologist and have a drain pulled, we're able to coordinate that so that hopefully patients can have more of a seamless transition out of the hospital. We strategically selected our clinic partners based on patients' social needs as well as their geographic needs. We're serving 3 different counties in our area, and transportation is a major barrier for many folks, so we tried to be strategic about our clinic partners in that regard. And then also chose partners where, for example, at the Old Town Clinic, which is part of Central City Concern, we have integrated behavioral health. There's access to addiction resources. And finally, because the health system is fragmented, we've introduced monthly meetings that bring together a diverse set of providers that are both inpatient and outpatient providers. So we have inpatient pharmacists and outpatient pharmacists, inpatient nursing and outpatient nursing coming together around the table, and we ground our improvement and program and discussions in these individual patient cases. So reflecting back to Steve's story, it could be useful to kind of think about how his experience might have looked different if SITrain had existed in 2008, so from his first hospitalization. And from the patient's perspective, patients have a care plan that identifies their unmet needs, and this happens early in hospitalization and can really guide some of the anticipatory planning across settings. Patients receive targeted education. This is both with support of the personal health record, but then also education that supports how to self-manage wounds and how to self-manage insulin and how to manage heart failure, for example. Many of our patients get a home visit after discharge. Some may get a phone call. They have access to their needed medications. They have close follow-up with a primary care provider who has information about what happened to them in the hospital. And they have access to post-hospital specialty care within the short time frame after hospital discharge. And they also have access to ongoing primary care. And one of the things that we've learned through our implementation experience is that I mentioned before the strategic selection around the primary care, certainly linking with primary care in a setting where there is integration with housing support and mental health support has been really key. So just to share with you a little bit about where we're headed, through our own local coordinated care or regional coordinated care organization, SITrain is going to be expanded beyond the initial internal medicine population that we've studied. and will be expanded to 3 area hospitals. So just a little bit of background about CCOs in Oregon. Really the centerpiece of health reform in Oregon are these coordinated care organizations, and the major delivery systems are coming together to think about how can we better deliver care in a coordinated way and really sort of drive reform. And so SITrain has been selected as one of the key pieces to drive this engine. And as part of our work, it's really important not only that we deliver this intervention, but that we use this as an opportunity to continue our own quality improvement efforts. That's been really critical. So a few suggestions for the group, and then we'll be glad to answer your questions. For those of you thinking about trying to drive local improvement, we would recommend that early on you consider to engage broad stakeholders, and I think this is really, it's not a one-time stakeholder engagement thing, but really from the stages of program development and certainly in implementation, it's really critical. I think it's important to recognize that local needs, that needs are local and opportunities are local, and so understanding your own context is really key. I don't think that there are any off-the-shelf improvements, and tailoring these various models to local settings is really important. We've found that there's tremendous opportunity in terms of partnering across settings, and this is really both from the perspective of the healthcare system, certainly our patients experience this improvement, and I think also our community partners feel great benefit in this regard. As I said before, the importance of local and regional context, and then just to appeal to leadership. We'd be certainly glad to answer any questions that you have. And we'll pass it back to Sabrina, who's going to moderate the Q&A.
Thank you, Megan and Nora. At this point, I will begin the Q&A session. If you have a question, please enter it into the Q&A chat box. So the first question has 2 parts, and the question is, were Healthcare for the Homeless consumer advisory boards involved in informing your needs analysis, and what role could consumer leaders play in advocating for policies that put care transitions in place?
So this is Nora. I'll try to answer that question. In terms of our own program development, we worked very closely with the leadership at Central City Concern and the Old Town Clinic, which is the FQHC in the Portland area that primarily meets the needs of our patients with homelessness. And we also have had a strong relationship with our recuperative care program here locally, and so in fact the representative from Central City Concern who came to our monthly quality improvement meetings is also the director of the recuperative care program. So having that kind of involvement both early on as well as we've been in the implementation and improvement stages has been really, really valuable. I don't know that we were sort of officially linked with a consumer advisory board, but that kind of the close partnership has been really key. Can you remind me of the second part of the question?
Sure. The second part of the question was, what role could consumer leaders play in advocating for policies that put care transitions in place?
I think that's a great question. In my mind, there's a number of ways that that could move forward. I think the partnership piece is really important. I would argue that local communities could really think about kind of community standards of care around these issues, and I think certainly the payment piece is really important in terms of driving reform. Where does what are the incentives for primary care clinics and community organizations to be more involved in the transition? But I think highlighting the partnership is really key. I don't know if Meg, if you have anything to add.
I agree. I mean, I think sort of from the experience here, it was, I think hearing Nora talk about the experience, it sounds like it was really kind of an organic experience that sort of just came from really reaching out to the community. And so whatever direction that outreach comes from, I think just spurs the project forward.
Mm-hmm. One other thing I'll just add for those of you sort of wanting to make these improvements, I can't emphasize enough the importance of telling patient stories to highlight these gaps. I think it's so critical because there's a way that it grounds the conversation, focuses the attention in the right direction, which is really how are we going to improve the patient's experience and the quality of care. The cost argument is one that is also very important. But by telling patient stories, we really were able to appeal to a broad group of stakeholders.
Thank you. The next question is, has there been a large-scale assessment of medical respite programs? And if you could answer that for the Portland, Oregon area, then I can answer that in terms of other states in the country.
You know what? I'm going to turn it to you, Sabrina. I'm not sure.
Okay. There are some large-scale assessments of medical respite programs. HRSA, the Health Resources and Services Administration, did finance a demonstration program that took place several years ago, and it looked at 10 medical respite programs across the country, and there is an evaluation of that program on our website. There's also recently an evaluation of medical respite programs that was conducted by WestStat, but supported by ASPE and HRSA, and that looked at 4 different programs nationally, and it does provide some information about cost and outcomes, but the studies that are available right now, those large-scale studies, don't really look at care transitions, and so that's one thing that we are looking at, and there is one effort in place right now to look at medical respite programs and how well they're integrating these interventions that are known to be successful. And so let me get to the third question. Do you work with homeless outreach workers, and are they part of your monthly meetings?
So we do, well, the way that, I'm not sure exactly what you mean by homeless outreach workers. I think that could mean different things in different settings. As I mentioned before, the strong partnership with Central City Concern, which really has a broad-based efforts around doing outreach with homelessness has been really key. Our nurses, for example, also, so for our patients who don't have housing as part of this home visit, our nurses will meet patients either in the clinic or at a coffee shop or kind of, on a park bench, and so we've been able to link with patients in the community successfully, and that's been a piece of it, is selecting nurses who are skilled at doing that kind of outreach as well.
Great, thank you. The next question is, does SITrain integrate any of the existing models, for example, Coleman's model?
So, yeah, I mean, I think that there are pieces. For example, the most analogous piece to Coleman's work would be the nurse piece, and he did home visits with nurse coaches. And so our transitional care nurse does sort of do some of this. I think how relevant the coaching model is really depends a lot on individual patients' ability to, in just in terms of their needs. So I think, if you think about a hierarchy of needs, the coaching, if a patient is capable of being coached, we really emphasize that and try to focus our efforts there. There are other times when it's perhaps more relevant or applicable that a nurse sort of moves out of a coaching model and is helping patients more directly. So there's a balance there, but certainly, we've borrowed from Coleman's work, we've borrowed from the Project Red work around some of the pharmacy pieces to inform our development. I think the pieces that are not present in these other interventions really are the system integration pieces and these clear partnerships. And that's been something that in our setting has been really important.
And I think having the access to primary care services, so maybe that coaching can happen over a time period and in not such a compressed period of time at the time of hospital discharge, I think is something that is maybe a little bit more unique to the SITrain innovation.
Great, thank you. This next question is actually referencing the policy brief that we will be releasing in the near future, and it asks about some of the recommendations that were included. And I'll just briefly go through some of the bullet points in terms of the recommendations that we offer. And for practice, that is to look at standardizing your care transitions process, much like they've done in Portland with the SITrain model, identifying expectations for cross-site communication, developing strategies to align existing initiatives to improve transitional care. For example, a lot of communities already have initiatives in place like the patient-centered medical homes and meaningful use of electronic records. So how is it that you can build upon those models in order to develop your care transitions program? One of the things that we also recommend is having a staff person at your primary care facility. So if you're working at a health center, have a staff person act as a hospital liaison who can be the point person for the hospital communication. Increase accountability for care transitions. For example, make sure that there is an entity, whether it be the hospital or the primary care provider, who is taking ownership of that patient's care during that transition phase. There are some recommendations around transportation and also including care transition interventions that promote housing placement and stability. Also engaging in continuous quality improvement and exploring opportunities to receive technical assistance through some of the health reform efforts that we described. The next question is what role and who is the COO in Oregon? And do you have contact with them?
So I think the question is around the CCO, or the Coordinated Care Organizations. And so the Coordinated Care Organizations, it's our regional CCO is called Health Share of Oregon. Who is part of the CCO? We've convened sort of the large delivery systems, and so for example, OHSU, and we have the Legacy Healthcare System, the Providence Healthcare System, Kaiser Healthcare System, our county system. All of these diverse providers and sort of health systems have come together to form the CCO, or Coordinated Care Organization. I've been very involved in the clinical leadership in terms of, there's sort of three major parts. There's clinical transformation, administrative transformation, and then financial and risk transformation. I've been very active in terms of the leadership with clinical transformation, in large part because of the experience that we've gained through SITrain. So it's an ongoing and developing process, very much as we speak. So I don't know if I answered your question there, but the who is a broad question. We do have, if anybody's interested, you can Google Health Share of Oregon, and then also the Health Commons Grant is another resource that describes our sort of springboard grant to jumpstart the CCO process here locally. So I have a lot of contacts with them.
Thank you. And the next question is, some care transition programs, including Coleman's, have used social workers as care coordinators. Any thoughts on this approach?
So I think it's a great question. Coleman's initial paper was RN-based coaching, but I think that it really remains to be known whether or not, sort of what is the role for social work versus nursing versus community health worker. And I think that the royal we in the health systems research community really don't know the answer to that. I think that for medically complex patients, the role of a social worker in helping bridge a transition could be a very important and powerful choice. Locally with our expansion that I mentioned earlier, we have elected to continue using transitional care nurses, but though we certainly considered the role of social workers, we found that because of some of the other community improvements around interdisciplinary community care teams and community health workers in the community, we thought that from the perspective of a hospitalized patient with complex medical illness, a nurse role probably was the way to go. But I think, again, it's the contextual factors that can really help inform that choice.
Yeah, and we work at Old Town Clinic. We work very closely with a community mental health program, and they utilize social workers in a huge way to, help people who are struggling with persistent mental illness transition from a hospital back into the community setting. And so I think it remains to be seen how we sort of think about providing transitional medical care services for people who might be struggling with serious mental health issues in the future. I think that's an area that, is sort of unknown also.
Okay, so the next question is, how well has SITrain been accepted by hospitalists and discharge planners at OHSU, and how many outreach nurses do you have on board currently?
So maybe I'll start, but I'll pass it on to Meg, who's had the most recent clinical experience as providing care in the hospital. My sense, so we currently have one nurse. And the nurse caseload is roughly 20 patients per month. As I mentioned before, we're expanding, so we're actually in the process of hiring on two additional nurses at OHSU, and then we'll have a nurse at each of our legacy hospitals that we'll be partnering with. I think in terms of the hospitalist experience, and Meg may have other insights, but generally it's been very well accepted. I think our hospitalists are delighted to have systems in place to help bridge some of these gaps. And similarly, our outpatient clinic providers, I think, have been very, very pleased with the work.
Yeah, and it's nice. I mean, I think I've seen it from both ends. Being in the hospital, it's certainly changed the way we practice, I think, in the hospital in the last, 2 years. We meet on a daily basis, and we identify very early if somebody would benefit from the Care Transitions program very early in their hospitalization so that we can start planning, start the patient education, and that is a dramatic difference from 2 years ago where suddenly we were ready to discharge the patient and realized that they were uninsured and had no resource to receive ongoing care. So I think the focus has really shifted, and I think it's become a much more satisfying way to practice in the hospital, and that's been my observations in the hospital. And then on the other end, it's been really satisfying to continue to provide complex medical services to people who really need them, and to be able to do that has been very rewarding.
Great, thank you. I think we have time for another couple questions. And this next question is, have you had any success with preventing readmissions for patients who are non-compliant and or an active addiction or have drug abuse issues?
So that's a great question, and in fact highlights one of the major limitations of, or I don't know limitations, but it's a really good question. And so, our primary outcomes were 30-day readmissions and ED use at 30 days. And we found actually, and we're sort of in the process of getting a more complete data set. So we used administrative data from OHSU records, and then we also used patient self-reported data. We called patients 30 days after their discharge, and we did baseline surveys. We in fact found that when you look at the entire cohort, there wasn't a difference in terms of readmission rates. But when looking by certain subsets of patients, there may in fact be a difference. And so, readmissions are a really complicated outcome. There was Meg's slide earlier showing the numerous drivers. In terms of really engaging with patients, our feeling is that it's difficult to know which patients to target. And certainly I think the question had to do with patients who are suffering from addiction and other mental health issues. We found that a certain amount of engagement has really been important in terms of doing the intervention. Another piece in terms of the outcomes, because I think it is an important one, and again, I say this with the caveat that we've yet to fully validate these findings, but our initial data suggests that there's a mortality difference and certainly that there's a quality difference. So patients reported better quality in terms of the care transitions measure. But our initial, and again, I hesitate to sort of say this fully because it's a big deal to say it, but the mortality data does suggest that some of these readmissions may in fact be saving lives. So, so stay tuned on that front.
Great, thank you. And that's all the time that we have for questions. We do have a few other questions and comments that we will address as part of the archived webinar, which will be emailed to all participants. Remember that this webinar will be archived on our website at www.nhchc.org within 72 hours, and you will receive a link to the archived webinar in an email. At the close of the webinar, you'll receive a survey to evaluate this webinar. Please complete it so that we're able to improve your webinar experience. And please visit our website for listings of upcoming council webinars and other educational products. Thank you so much, Megan and Nora, for your wonderful presentation. At this point, I'd like to close the meeting. Thank you.